Thank you very much, Manal, and I'll go straight into it. So, good afternoon and good morning, good evening to everyone. And just to say that we are going to give a presentation on validation of elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B virus, or being on the path to elimination. And we are going to focus this very much on Namibia's silver and bronze tiers, but we are also going to do this in the context of the global level. This slide actually gives us a picture of where we are with triple elimination and its validation. As you know, it started in 2010, and that's when PAHO decided that really there is a need to have a goal for PMTCT. And so by 2015, this was got, and then Cuba was the first country which was validated. Now, we had a lot of countries since then, a total of 21, and we know that it's very possible to do this elimination when there's low prevalence. But the burden is mostly in higher prevalence countries. And in these higher prevalence countries, it's difficult to meet these targets. And we'll go a little into more detail in the further slides. But just to say that from this slide, you can see that only one country so far has applied for triple, and that is Namibia. And it applied for triple elimination, path to elimination, and not elimination itself. But we know also that more than 50 countries have shown interest in implementation and the validation of triple elimination. And WHO provides support directly or through backstopping of the regions to countries, noting that our target is to validate 100 countries by 2030. Next slide, please. So this shows us that validation is mainly to attest that a country has successfully met the criteria for PMTCT, whether for elimination or path to elimination. We have 4 foundation areas which are shown here, which are assessed or reviewed. And these are programs and services, laboratory services, surveillance and data, and then human rights, gender and community engagement. Now we look at these 4 foundation areas as well as the other criteria and targets and see whether the country has been able to meet these. Next slide. The criteria are shown in the next slide, and that you can see we have impact and process criteria. Now the impact for HIV and syphilis are very similar in that both of them have a case rates of less or equal to 50 per 100,000 live births. HIV has an extra impact criteria of the mother-to-child transmission rate, where we look at 2% if it's a non-breastfeeding country or 5% in breastfeeding populations. And this is decided by the country policy. Process or programmatic criteria are antenatal coverage, testing coverage, and ART cover or treatment coverage for HIV and syphilis. Hepatitis is slightly different. They also have impact criteria, and these are shown by on the last column on your right, where 0.1% prevalence of hepatitis B surface antigen in less than 5-year-olds is what is used, with an additional MTCT rate for countries that use targeted birth dose. The programmatic criteria are different in that we're looking at immunization, because we know that this is the most effective way of preventing mother-to-child transmission. And we are looking at 90% coverage of hepatitis B3 and also the timely birth dose, if a country has universal birth dose. However, if the country practices targeted birth dose or does not have a birth dose, we use those 2 criteria. And in addition, we look at the coverage of maternal testing, as well as the coverage of antiviral treatment or prophylaxis for those who are eligible. Next slide. So part elimination really came up, like I said, because we have countries who have a higher prevalence, and the background prevalence makes it almost impossible for those countries to reach those targets that we showed in the previous slides. However, we use the same process and tools for assessment, the same MTCT rate for HIV and syphilis, and you can see at the bottom of the slide for the path to elimination, we have 3 tiers, bronze, silver, and gold. And you find that we're looking for HIV and syphilis at the coverage, case rate, and then also the MTCT rate. But the MTCT rate must be less than 5% for all the tiers. The difference is in the case rate, where we have a 750 instead of less than 50 for bronze, 500 and for silver, and 250 cases per 100,000 live births for gold. There is a difference in the programmatic coverage in that bronze and silver also have 90%, whereas the gold has 95%. Hepatitis is shown lower down in square boxes, and it is much simpler. First of all, for bronze, all a country needs is to have more than a 90% hepatitis B3 vaccine coverage. They need to have the policy to implement universal timely hepatitis B birth dose. With silver, you also need to have the 90%, but then more than 50% timely birth dose and availability of the antenatal surface antigen testing in the public sector. Gold is much closer to full validation, where we have the 2 coverage for programmatic, as we've shown, more than 30% of antenatal testing being done in the country. Next slide, please. So with all this at the back of our minds, we need to know which countries are eligible for path to elimination, and this included Namibia. Now, any country which has strong programs and making significant progress can apply for certification through the path to elimination. And on the right, you see what is needed for prevalence, seroprevalence, to be able to assess the elimination, the path to elimination. That's the criteria. So you need to, in that country, have a reported maternal HIV seroprevalence of more than 2%, syphilis reported maternal seroprevalence of more than 1%, and then for hepatitis B, which is mainly our concern here, estimated prevalence in 5-year-olds of less than 1%, or in the general population is 5%. Oh, sorry, not less than, greater than 1%, or in the general population, greater than 5%. In these countries, they also should have made a significant progress in implementing hepatitis vaccination interventions alongside testing and prophylaxis for the women. These are very important because for us to really progress in these countries who haven't been doing hepatitis vaccination, especially birth dose, for a long time, we have these issues that must be covered. Next slide, please. So after the release of the new global guidance in 2021, countries were then assessed for triple elimination, as Casimir described, rather than for dual, which was HIV and syphilis. And Namibia in particular has several years of really strong programmatic implementation, and there was keen interest in showcasing their progress. So these characteristics included strong political will and ownership, a tremendous improvement across the basic and MCH indicators in the past 20 years, strong health systems, policies and practice. They have surveillance systems, which still need strengthening, but were good enough to apply, and also a strong lab network with well-coordinated QA. but there were some limitations in human rights, gender equality, and community engagement. Namibia was the first country globally to go through the full assessment process and submit the request to the Global Validation Advisory Committee for the certification of achievement of being on the path to elimination. After reviewing their report, it was found that they had achieved the process and impact targets for HIV and hepatitis, but not for syphilis. And syphilis, as often happens in our region, we had challenges with data and the real coverage of the interventions, reporting on them to be able for this to be assessed. So Namibia was certified for being the first country to complete the global review, even though they did not achieve for syphilis, and they were found to be on the silver tier for hepatitis B and the bronze tier for HIV. In the next slides, we'll show you how this pans out. It just, as we previously described, silver tier for HIV meant they had 90% coverage in ANC, in testing, and also ART for HIV. For syphilis, they did not meet this because we did not have enough information to judge. But then for hepatitis B, it's of interest that the programmatic targets are what we look for path to elimination, and impact targets for hepatitis are not required. The next slide shows us the bronze tier, and for the bronze tier, 90, 90, 90 as described. Again, we didn't look at syphilis, but then for hepatitis B here, we found that Namibia had a more than 90% coverage of hepatitis B infant vaccination, and they were implementing universal timely birth dose. Next slide, please. These are the documents which are used. This is the guidance which WHO has developed for countries to use in preparing not only for implementation of responses for elimination, but also for the validation. So to know where we are, we need strategic information, and there we have guidelines for those. We also have the information source of the Global Health Observatory. And then we have an implementation framework and guidance which helps the country to actually prepare and ensure that they are implementing enough at a proper scale to achieve elimination. This includes provision of testing, and then there's a minimum package of interventions which should be planned and implemented to get there. There are also the standardized criteria and processes. Next slide. And they are all shown in these diagrams. So in Namibia, we found that there was a lot of consultation and coordination. Namibia had a roadmap for maternal and child health in place. They reviewed it, and after discussion, they added an addendum which made it possible to address triple elimination instead of dual. So then they added hepatitis. Immunization was there already, but it's important to note that there's more to path to elimination of hepatitis B than just immunization. Immunization really is the entry point, but there are other responses which have to be applied. Then they also strengthen the linkages between the disease programs, that's the HIV, and they in Namibia call them special programs, and then the RMNCH program or platform. Namibia also did a pre-assessment. We jump-started the validation process, and this is a preliminary rapid review that provides an overview of the potential status of a country for PMTCT validation, and we use this to make their strategic planning efficient, such that by the time they were ready to apply, many things were in place. So the last thing was the cross-cutting implementation considerations, where we looked at health system strengthening, strategic information, leadership and partnerships, and then community engagements. Now, strengthening the 4 areas, like I said, was extremely important. And some good practices from Namibia include the political will and commitment. The country showed this very clearly. Integration and coordination, there was willingness to make sure that integration and coordination were really efficient, with disease control and RMH NCH responses from national policy all the way down to service delivery. Then there was cross-programmatic coordination led by the Ministry of Health with country ownership. And one thing which a lot of countries are not very good at this time is the coordination with immunization, because immunization is not always seen as part of the disease control. I mean, immunization itself does not deal with individual diseases, but has them in groups according to the vaccinations given. And then lastly, the integration of service delivery. And the typical example here was that midwives were providing immunization services on the delivery platforms, which made it very easy to ensure that all the children who were born actually received timely birth dose and didn't have to wait for an immunization nurse to come over to bring this. So thank you very much. And I think that's the presentation, which gives an overview of the global level and also what happened in Namibia. Thanks very much.